Thank you very much for inviting me along to Paediatric Emergencies 2021. I'm Thomas Waterfield, and I'm going to talk to you about Paediatric Multisystem Inflammatory Syndrome. This is also known as Multisystem Inflammatory Syndrome in children, or MIS-C in the United States, and more internationally. For those of you who don't know me, I am a Paediatric Emergency Medicine Consultant at the Royal Belfast Hospital for Sick Children, and I'm also a lecturer in Paediatrics at Queen's University. And my research interests are all around paediatric infections, including COVID-19. So we're going to build this around a fictitious case of a 12-year-old boy who's had multiple attendances to the emergency department and has some ongoing diarrhea and abdominal pain. He's pretty lethargic, and he looks dehydrated, and he's commenced on some IV fluids by the junior doctor. When we think about PIMS-TS, it's actually got a lot of overlap with common conditions. So it will be typical for these children to present multiple times to either GP or hospital. It is typically a kind of slower developing illness than some of the differentials such as sepsis and toxic shock. And they do have a tendency to kind of creep up on you, just gradually deteriorating. And I certainly think back to some of the first cases that I'd seen, were certainly admitted, and there was some kind of discussion and debate about whether they were PIMS before they were finally treated. The symptoms are common, so gut symptoms are really common. As part of the SARS-CoV-2 research that we conducted last year looking at the symptoms of SARS-CoV-2 infection in children, we actually found that abdominal symptoms are really common in acute infection, and they seem to be a really common feature in PIMS-TS. Then also conjunctivitis, and alongside that rash, the skin changes are really, really common. So you're seeing about half will have conjunctivitis or rashes. Persistent fever is there in all. And then commonly kind of a big difference between this and say Kawasaki's disease, which is a vasculitis in childhood, which we would see and we would be familiar with, is the acute cardiac compromise. So whilst coronary artery aneurysm formation is well reported in Kawasaki's disease, the kind of hypertensive cardiac shock, which is pretty typical of PIMS-TS, isn't something that we would see in Kawasaki's disease. Other sides, so laboratory findings, you usually see evidence of hyperinflammation with very high CRP levels, raised ferritin, profound lymphopenia, thrombocytopenia, neutropenia, and abnormal cardiac enzymes and D-dimers. For anyone that's looked at the UK guidance from the Royal College or the Lancet paper on the kind of consensus guidelines around PIMS-TS, you'll see there's an awful lot of investigations listed. Investigations that myself as an acute paediatrician and certainly many of my emergency medicine colleagues wouldn't be familiar with in children. So that includes interpreting results such as D-dimer, troponin, and BMP. So before we send those investigations on children, we need to to consider whether they're necessary and what we're going to do with the results. So a bit more information on our case. So our 12-year-old child actually was COVID positive a month ago. He was fine. It was through the whole family, and he was actually probably the least affected. But now he's had 6 days of fever, and he just feels pretty groggy. He's a little bit tachycardic. His cat refill's okay, but he's hypotensive, 88/60. Now you've done this 6 times because he's sitting there chatting to you. The junior doctors gave a fluid bolus, but has made no difference. But despite this, he's sitting there chatting away, and this is really completely typical of cases that I've certainly seen, and very reminiscent of the case I saw when I was working in Dublin Temple Street, one of my first cases of PIMS, which is a child sitting there chatting away with me despite having a pretty awful blood pressure. And then the blood results come back, the CRP is over 300, the child is hyponatremic, lymphopenic, and there is a coag, not a fibrinogen of 7. So at this point, you actually pretty much have your diagnosis of PIMS-TS. And your first line investigations are nearly enough to give you the case. Now, not all cases of PIMS-TS are this clear cut, and certainly there'll be lots of querying and further investigations needed in many, but this would be pretty typical. So go back to those diagnostic criteria that we talked about. So you must have evidence of inflammation, that's prolonged fever over 38, and really you need to have laboratory changes as well. If a CRP is less than 100, it's either very, very early or just not PIMS-TS. I'll bring some data up later on, but the kind of median CRP values are up over 200. You should have a neutrophilia, and you'll typically see a lymphopenia with lymphocytes less than 1. And then there'll be single or multi-organ involvement. Cardiogenic shock, and I'll bring up some numbers on the frequency of this, but certainly cardiac dysfunction is fairly common, as is abdominal upset and respiratory failure. Now, you will not typically see respiratory failure at all in Kawasaki disease. That is unusual. Abnormal neurology, I'm slightly skeptical about. This is reported quite a lot in the literature, but I wonder if this just relates to actually delirium secondary to being acutely unwell. I'm not, my personal experience and from what I've seen for the children coming through in the study that we're running, I wouldn't say that's a key feature, but certainly delirium would be. So where can we get some data from? So let's have a think about where the sources are. So certainly in Northern Ireland at the early stage of the pandemic, we weren't seeing large numbers of cases of PIMS-TS, and that probably reflects the fact that we saw very few children during the first wave. Our first wave in Northern Ireland was quite muted compared to that of England, Scotland and Wales, and we're certainly seeing now a more sustained kind of wave, and we're seeing far more cases of PIMS-TS coming through the Children's Hospital. If we look back at data from England during the kind of early stages of the pandemic, that first wave, there were 268 PIMS-TS cases over really kind of 3 to 4 month period. Now, the median age of these children were 8 years old, so this is a little bit older than what you would see with things like Kawasaki's disease. And it was more common in males, more common in children with Black and Asian heritage, although that reasons for that aren't really clear. That may just represent kind of socioeconomic groups rather than a genetic predisposition. More work's needed on that, really. And what's really striking is that nearly half of these children needed to go to intensive care units, but thankfully very few died. So this is actually a brand new illness that we're seeing that causes really quite significant harm in children, and we do have to be vigilant for it and try and understand what's going on. Now, there's different ways of categorizing this, and it has an awful lot of overlap with Kawasaki's disease and also toxic shock syndrome. And actually, they talk about the phenotypes of PIMS-TS in that way. So there's either the toxic shock type, which is the one I think we think the most about because they are the ones who are hypotensive, who look very, very well and are most likely to need ICU. There's those that look more like a typical Kawasaki's disease, and it's now very, very hard to really be certain of Kawasaki's disease certainly during this current wave of infection, where nearly everyone will have been exposed in the last couple of months to SARS-CoV-2 with the increased infection through schools. And then there's a kind of in between neither. And talking to my colleagues in infectious diseases at the Royal Hospital, that would be their kind of description that these different kind of phenotypes exist. The symptoms of this is actually just taken from the supplementary material from the same paper from Public Health England, but that you see there, 2/3 of children will have a rash, about half will have conjunctivitis, abdominal pain, diarrhea, vomiting, really common. So certainly if you have a child that looks very unwell, has persistent fever, is an older child, and they have gastrointestinal symptoms, you should really be tuning your radar towards, could this be PIMS-TS? So our under fives, yes, we used to have being quite labile with a temperature, but we're not used to seeing that in children at 8, 9, 10 years old. So high fevers, GI symptoms during, or kind of several weeks after a COVID surge or COVID wave, you should really be mindful of PIMS-TS. Hypotension, so it's really important to get blood pressures as we get busier and busier. If they're not a standard part of your triage where you are, then you need to ensure that they are done in these children. Evidence of mucositis is pretty common. Lymphadenopathy, and I've certainly seen a case of a child who presented with a neck swelling and had concern from kind of ENT colleagues that it was a retropharyngeal abscess who actually had PIMS-TS. Cough is in there probably to represent some of the respiratory failure that can happen, but I wouldn't say it's a key presenting feature of PIMS-TS, and that would be more in keeping with acute COVID infection. So laboratory findings, again, just taking from actually the supplementary material within that PHE paper. Your median, these are median values. So your median CRP is over 200. So although we've said actually over 100, most will be over 200. Ferritin over 500, D-dimer over 3,000, fibrinogen over 5.5, lymphocyte count less than 1. And these would be the kind of typical values. So we're talking about a very, very deranged set of blood results. So our case, we go back. So he's sitting there, he's hypertensive, hyponatremic. He's got a very, very high CRP. He's no chest pain, there's no cardiac history. You're in a district general hospital, and actually you're just not able to get anyone to perform an echo there and then. So you perform an ECG. So ECG changes are fairly commonly reported in PIMS-TS. And the most common findings that you see are a flattening of the ST segment, T-wave segment initially. You can see that in slide A, and this is all taken from a really nice paper from the Evelina Hospital where they looked at around 60 different children with PIMS-TS and their ECGs. When you'll see a gradual change of that with T-wave flipping through B and then through resolution, you'll see in C and D with that returning to normal. Occasionally, you'll see ST changes, which you'll see in E and F. Despite having ST changes, there haven't been any myocardial infarctions reported that I'm aware of in PIMS-TS. The insult is all around a kind of myocarditis with significantly impaired ventricular function on echo. So we've got our case in front of us, and we're getting very excited that this could be a PIMS-TS, but we just have to be mindful that this is actually an older child who is hypotensive, looks very, very unwell and has very deranged bloods. And actually before COVID, we would have been thinking about sepsis or intra-abdominal sepsis. And certainly we have to keep our minds open in that. So we're thinking about your surgical consult, thinking about giving your broad spectrum antibiotics to cover for serious infection. We're thinking about your sepsis management. Kawasaki's disease, again, so Kawasaki's disease has some overlap. You'll see this is a really nice figure taken from a French paper. It's been, I think, referenced nearly 800 times now. It's an incredible paper. But just looking at features from Kawasaki's disease, you can see there conjunctivitis, mucositis, cervical lymphadenopathy, skin rashes, pericarditis, coronary artery dilatation, which are common to both. But then you'll see actually the neurological signs certainly more common. As I said, I wonder if that's to do with delirium and just how well they are. Respiratory signs, just not a feature of Kawasaki's disease at all. Left ventricular dysfunction, which was very high, reported much higher than it is here in French studies. Shocked, and actually needing ECMO, which is, again, none of our children online have needed ECMO as far as I'm aware yet. GI involvement are there really high as well, as you'd see. So some really key differences between Kawasaki's and PIMS, and also with sepsis. And again, there's also toxic shock on there. So you need to keep a broad diagnosis in mind, not just jump to a diagnosis of PIMS, and make sure those different conditions are covered. So what's happening? So we don't really quite know what's happening in PIMS-TS. So one of the reasons I was invited to give this talk, I'm an emergency medicine physician, so I'm not an infectious diseases consultant, but my research is around COVID-19. We have an ongoing study looking at symptoms and antibody kinetics in children, but we now actually, with the recent recruitment, we've got a study ongoing looking at PIMS-TS, and we're looking at a kind of multi-omics approach to try and understand the immune response in children with PIMS-TS and how that compares to other common paediatric illnesses. So different theories have been put forward. This is a really nice figure taken from an adult paper, just showing how you kind of initially become exposed, you're asymptomatic, doesn't really affect you, and then kind of initial viral stage, fever, cough, those symptoms are all kind of aware of. In children, we get a little bit of that, but then it quickly drops away with no kind of hyperinflammation, and then a really tiny blip at the end where you get the MIS-C, and then you'll see between the adults and the old adults in between getting that hyperinflammatory stage in the middle. And I'm not going to dwell on adults because I don't think it's the same illness, and I'm a paediatrician, but I think there's certainly good evidence around endothelial involvement and a kind of endothelitis, which is probably multifactorial. It probably relates to kind of pre-existing injury. So certainly if you think about your risk factors for severe COVID infection in adults, they are people that are predisposed to kind of inflammatory changes within the vasculature already, and to have kind of damaged or sick endothelium. And I think endothelitis is a big part of acute COVID-19, but also in PIMS. This is a figure just from one of our papers we're putting together, Just kind of summarising, we performed a literature review and just looked at studies that were looking at the mechanisms behind PIMS-TS. And there's lots of different kind of theories. It's hard to tie them all together. So one of the things that's been put forward is around the antibody response. So you're getting your kind of antigen percentage or kind of B-cell antibody response, and you're producing non-neutralizing antibodies as well as auto-antibodies. And it has been shown an antibody to endoglin, which has a really key role in the maintenance of endothelial cells. That's been identified in recent autoantibody studies, so showing that there's probably some sort of potential autoantibody mediated injury to endothelial tissue as part of this. But then these non-neutralizing antibodies can also then become kind of self-stimulating, which leads to a cytokine storm. And the kind of cytokine profiling showed it is slightly different to infection and also to Kawasaki's disease. You get very high interleukin-6, and you'll remember that interleukin-6 blockers have been considered as treatment. You also get high interleukin-17A. This cytokine storm probably is responsible for some of the kind of toxic shock appearance that you see. So we've got a cytokine storm ongoing, we've got leaky endothelium. We may have a role for autoantibodies. And then there seems to be, from some really small but neat studies looking at single cell RNA sequencing and looking at flow cytometry, that something is happening with natural killer cells and kind of exhausted CD8 cytotoxic T cells, leading to some sort of chronic inflammatory response. Now, all of this hasn't really been fully worked out, but it seems that there's the environmental trigger, which is SARS-CoV-2, probably some underlying genetic predisposition to a pro-inflammatory immune response that leads to antibodies that are produced that include autoantibodies, but also self-stimulating, non-neutralizing antibodies. This leads to kind of direct endothelial injury through autoantibodies, but also through a cytokine storm, which is then kind of perpetuated by abnormal kind of regulation or dysregulation between cytotoxic T cells and the other major cytotoxic cell, which is natural killer cells. But more work's needed to really understand this properly. So the case was referred on. So we know that around half of these children are needing to go to the intensive care unit. We know that acute surgical pathology is often a common differential. We know that many will need echocardiograms and will need input from cardiology. So the place really for PIMS-TS to be primarily managed is in the Children's Hospital, where there's a multidisciplinary team to manage them. And I know from working very closely with them as part of the study, they're happy to always take calls on patients with possible PIMS-TS. This child was transferred across by NISTAR, was commenced on immunoglobulin, commenced on high-dose steroids, and made a reasonable recovery initially. Follow-up has showed that they've got some ongoing coronary artery the abnormalities are very prominent, but no dilatation and no aneurysms, and some ongoing fatigue. And certainly as part of the study, we have formed a patient public group, and one of the young people involved in that was a very keen athlete prior to PIMS. And although kind of some of the key markers around echocardiogram have shown kind of return to normal function, he still has significant ongoing fatigue. His exercise tolerance is significantly reduced. And that raises some really interesting questions, because is this just recovery from a severe illness, or is this some sort of ongoing inflammatory response? And that probably hasn't really been looked at yet in terms of is the actual inflammatory side of this going on and on. So I think just to kind of close up and summarize, PIMS-TS at the moment is fairly common. We're seeing 2 or 3 cases a week coming through the study, through the Children's Hospital. Diagnosis is probably tricky initially. These children that have had fever for 5 days might present when they've had fever for 2 or 3 days, and they certainly myself find that a tricky group. You had a fever for 3 days, you're over 5, you don't look great, you've got some tummy upset. My threshold for blood tests at the moment for those kind of children is a little bit lower than it was pre-pandemic. I don't do all of the Royal College Royal College investigations because I'm reluctant to interpret, for example, a D dimer, a troponin, and a BMP in all the children. So I'll typically do my first line investigations. If that points towards PIMS-TS, then I'll have that conversation with my colleagues in infectious diseases, and then perform my second line investigations with their support and also the support of cardiology. So I think at the moment, keep an open mind. We are seeing lots of cases. We don't really understand the mechanism. I think if you're vigilant and you're discussing them early, then they do pretty well. They can be challenging to manage and are probably easier managed where we have a mixture of teams, including ID and cardiology. And that's really kind of a short summary on PIMS-TS. So thank you very much for inviting me along, and I'll be around for some questions. Thanks.